Good afternoon, everyone, and welcome to the second event in our inaugural Fall Symposium series, the Veteran and Family Wellbeing Series, a person-centered, evidence-based approach to chronic pain. I'm Dr. Ramesh Zacharias, Chief Executive Officer and Medical Director for the Chronic Pain Center of Excellence. At the Center of Excellence, our mission is to improve the well-being of our Canadian Armed Forces veterans and their families suffering from chronic pain. In collaboration with researchers from the United States, the aim of the series is to provide education on the evolution of pain management and current best practices in evidence-based interdisciplinary care. Thank you all for joining us today. I'm now going to pass it over to one of our moderators, Eric B. Schoonmaker.
Thank you, Dr. Zacharias. We're very pleased today to have a special guest to introduce our session.
Hey everyone, I'm Austin Matthews from the Toronto Maple Leafs of the National Hockey League. I'm honored to be part of today's event led by the Chronic Pain Center of Excellence in collaboration with the U.S. Department of Veterans Affairs and the United States Department of Defense. As a hockey player and an athlete, we all experience chronic pain to some degree throughout our careers and even once we've hung up the skates. I've experienced all types of pain and understand the seriousness of chronic pain and the toll it can take on your body and your mind. Whether I'm experiencing pains from a new type of workout or my whole body after a heavy hit into the boards, I constantly push myself to be stronger and get better every day. As a proud American, I've been fortunate enough to grow up and live in a country with all the freedoms and opportunity in the world, and it's because of the commitment and service of our veterans that I'm able to play the game I love every day. Thank you for your service.
Bonjour, chers amis. Mon nom est Michel Maisonneuve et je suis un vétéran de l'armée canadienne dans laquelle j'ai passé 35 ans. Je suis honoré aujourd'hui avec mon collègue le général Schoonmaker de servir comme modérateur de ce webinaire. Over my 35 years in uniform, I realized that chronic pain is a constant in the lives of many of our sailors, soldiers, and airmen and women. And for many, this pain follows them into retirement. So it's my honor today, alongside my colleague, General Schoonmaker, to help moderate this second of a series of webinars dedicated to helping veterans who suffer from chronic pain. Je vous demande, si vous ne l'avez pas déjà fait, de vous inscrire dans le panneau à droite et vous pouvez poser vos questions de la même manière. Ensuite, il est plus facile de visionner le webinaire en mode plein écran. Pour voir les sous-titres en français, il suffit d'activer le mode Closed Captioning ou sous-titrage codé. C'est l'icône CC au bas de votre écran. À vous, Eric.
Thank you, Lieutenant General Maisonneuve. I'm Lieutenant General and Dr. Eric Schoonmaker, the former U.S. Army Surgeon General and the Commanding General of the Army's Medical Command. As I explained last week, General Maisonneuve and I both have an enduring commitment and a real passion to help those who have served in uniform and their families, especially during these difficult eras in defense of our two nations. I'd like to start off by thanking Dr. Ramesh Zacharias and his colleagues at the Chronic Pain Center of Excellence at McMaster University and for the Wasserman team for arranging for this series of now the second of 4 weekly webinars on the comprehensive management of chronic pain. I'm privileged to serve along with General Maisonneuve as the second moderator for today's very unique international forum. You in the audience can best join us by first registering, signing in via the information box, by asking your questions via the box in the right-hand side of your screen, by viewing this in the full screen mode, and for those of you who are French speakers to use closed captions. It's now my distinct privilege and honor to introduce a very close friend and a trusted colleague who has distinguished himself by his leadership in the U.S. Department of Defense and Veterans Affairs and the nation at large in the development of chronic pain management protocols and treatments. This is Dr. Chester, known as Trip Buckenmaier. He served for over 3 decades in uniform, retiring as an Army colonel in the Army Medical Corps. He's an anesthesiologist with special training in acute pain management. He serves as the director of the Department of Defense's Defense and Veterans Center for Integrative Pain Management, and has been really the single belly button for any questions and any policy developments and new protocols developed within the U.S. Department of Defense in the management of acute and chronic pain. He has been a passionate leader and an innovator that you'll hear about. And with that, I'm going to turn this over to Dr. Buckenmaier.
Hello, my name is Trip Buckenmaier. I'm a professor of anesthesiology at the Uniformed Services University, and I direct the Defense and Veterans Center for Integrative Pain Management for the DoD. I'm very pleased to be a part of this Veterans and Family Wellbeing series. I'm here today to talk to you about DoD pain management and opioid safety, some of the research, legislation, clinical requirements, and policy and actions that we've been taking. There have been a number of strategies that we have been affecting in the last decade regarding pain management. Are in particular because of service members in the last 2 decades of conflict that we've been involved in, explaining to us that our methods of pain management needed to be improved. I'm going to be talking to you today, starting up in the left-hand corner, about improved measurement in particular. This is probably the most important project from the standpoint of the cultural change that we're trying to affect in our culture regarding pain and its management. We're going to be talking about non-medication pain treatments, integrative health, which is now no longer being looked at askance in the DoD and is being looked at as an equal partner as far as the therapy and the management of pain. Improved monitoring tools, improved education projects like the Joint Pain Educational Program, and how we use Project ECHO to disperse that information. A more sophisticated way of looking at a patient from a whole health perspective and dealing with their pain. And then, of course, opioids. The education regarding the use of these medications, the consent process, and the use of naloxone in our system. Of course, as a federal agency in the United States, we are driven by Congress and legislation, and I just want to briefly mention the 2010 National Defense Authorization Act that charged the military through the Secretary of Defense with developing and implementing a comprehensive policy on pain management within our military health system. This policy was to be standardized, consistent throughout our medical treatment facilities, addressing both acute and chronic states of pain with what we call our roles of care. So roles 1 through 3 on the battlefield, and then roles of care back at home. It had to be appropriate both for service members and their families, a adequate research program to back up those activities, and include education and training for healthcare personnel. There were 2 documents that were involved in this. The first, and we're rather proud of this particular document, was our Pain Management Task Force. This report came out in May of 2010. You'll note that we were using words that had not been necessarily discussed before in the DoD, words like holistic, multidisciplinary, multimodal, state-of-the-art science to provide an optimal quality of life for soldiers and other patients within our system. Interestingly, this document was followed almost a year later by the civilian version of this report called Relieving Pain in America, a Blueprint for Transforming Prevention Care Education Research. I think it's interesting to note that the points of view from both documents were very complementary, and in many cases, with reading one, you're essentially reading the other, and we were pleased with that outcome. There are a number of novel pain methods and equipment available for use right now. Certainly Actique, the fentanyl lollipop, has been a very important innovation, if you will. It's still an opioid, but for acute pain out on the battlefield, it has made a tremendous difference. I think the problem, though, is that historically, our thinking on pain management on the battlefield has stopped with opioids. In fact, morphine has been the only answer in many cases in conflicts of the past for managing acute pain on the battlefield. But we have so many other tools that are represented here, and I'm pleased to say have been in relatively rapid fashion brought into our system. Things like acetaminophen, novel non-steroidal anti-inflammatories like ketorolac. On the other side of the screen, on the left side, you'll see a ketamine inhaler and then a device that's providing Actique, a sufentanil nanotab, which has recently been developed for our troops in the field. And so I want to say uncategorically that opioids are not bad. It's how we have used them historically that I think has been the problem. I would shudder to think about deploying, and I've deployed to both Iraq and Afghanistan, to try to provide analgesia in an acute polytrauma patient and not have these tools, opioids, available for use. In the center of the screen, you'll see an infusion pump, which has certainly made all the difference in our ability to manage pain and casualties in the current conflicts. And this is only supplanted by ketamine, which is probably one of the most significant analgesics that have come out of the recent wars, even though it continues not to have a FDA indication for analgesia. You'd be hard-pressed to find a military facility today that's not using ketamine for that case. But regional anesthesia has been another innovation in that it's provided a tool, particularly for extremity wounds, where we can literally turn off an extremity from a pain perspective. And it's been very useful for the evacuation of many polytrauma casualties. You'll see here a nerve stimulator. This is what I actually used in Iraq. This particular stimulator is in the medical museum right now at Walter Reed, which is a little freaky, but you can go visit and still see my name tape on that particular device. I have briefly mentioned that infusion pump, which allows us to provide continuous peripheral nerve blocks, an infusion of local anesthetic through one of these catheters to block these nerves. This is a casualty right here that received a gunshot wound to the chest. Historically, we would intubate this casualty before flying them to a new location. With adequate pain relief, though, provided by regional anesthesia, we no longer had to do that, and that's a significant advance. And then, of course, ultrasound technology. We're now able to see our targets for this regional anesthesia. It's really made all the difference. Ultrasound and simple laptop with the image quality that we have right now is extremely useful, not just for pain management, but for a variety of activities on the battlefield for managing casualties. But this also matters at home. Our Joint Commission, this is the organization that actually certifies our hospitals in terms of their ability to safely and effectively take care of patients. And they're looking at how we manage pain. And I just want to point out that they're asking us now to provide services, non-pharmacologic strategies, things like acupuncture, chiropractic care, osteopathic manipulation, massage therapy, physical therapy, and the like. And so this is a significant change in the regulatory policies that drive how we manage care. And we subject our military and our federal institutions to these same regulatory bodies. And so we're being told that we need to move in this direction. But I want to spend a little bit of time talking about pain and its measurement. It's interesting, while I may not feel this way as a clinician, patients actually listen to what we prioritize and what we think is important. And in the measurement of pain, if the only question you're ever asking a patient about about pain is its intensity, then that becomes the sole metric, if you will, on how pain is being measured. The service members coming back from the wars, at least in our country, while they admitted they were begging for the relief of pain and the reduction of pain intensity on the battlefield, if they had known what that would mean to their overall rehabilitation recovery, they would have begged us for something different. And in fact, other folks have begun to question whether or not pain intensity was the wrong metric and that we should have been possibly looking at other things. We've certainly come to that conclusion. And in fact, we developed what we call the Defense and Veterans Pain Rating Scale. You'll see some of the original research that was done on this scale. It is now the adopted and accepted scale for measuring pain within the DoD. And we're going to talk about some of the elements of this scale. Many of them you'll find very familiar. It still does measure intensity, but I think it provides far greater information than the standard 0 to 10 question that we're also familiar with. So you'll notice the mild, moderate, severe, no pain. We put this on here because we are a NATO ally, and many of our NATO countries only use this 4-point scale when they look at pain. You'll notice the faces, the bars, and the colors. You may ask yourself, why is this needed? Well, we do operate around the world, and we often operate and take care of patients that don't share our culture, our mores, or even our language, but they are able to respond to these various elements. And in fact, even our own patients oftentimes respond better to some of these other graphic elements than they necessarily do with numbers or language. But I do want to point to the bottom of the card where you'll notice that we've provided functional language for each one of these numbers. The standard 0 to 10 scale, which provides us a very nice way of defining pain, but we are helping the patient by providing these anchors on function. And so it's not just about intensity, it's about physical and emotional function. And we follow this up with some basic questions about how pain is impacting on activity, sleep, mood, and stress. And this allows for a very different conversation when it comes to pain between the clinician and the patient. A patient may have a pain intensity that traditionally we would treat, such as a 6, but they might be doing much better in terms of sleep, mood, stress, and their activities in the ways that they've been interacting with the therapies you've been providing. That's not a patient that needs more drugs. That's a patient that needs to double down on those non-pharmacologic approaches that are improving their function, both physically and emotionally. Of course, this needs to be integrated into our workflows, and we've been providing those clinical workflows, particularly for our primary care community. I will admit that this tool does increase slightly the amount of time it takes to ask the basic pain question, but the amount of information that's received from the Defense and Veterans Pain Rating Scale is far greater than you receive from a simple standard pain intensity question. I'm briefly going to discuss a program we call PASTOR. All of these tools, by the way, you can find on our website if you want more information. But this is a more detailed dive and leverages what we call PROMIS instruments from the National Institutes of Health. And these utilize computer adaptive testing. And so I'm able to expose a patient, let's say, to a 50-question bank on physical function, but I only have to ask 4 to 6 questions to get a more statistically valid answer in a very short period of time. This provides the clinician a report on the patient's pain, has key areas such as the pain map by region, provides clinical alerts on some important topics like possibly alcohol abuse, suicide ideation, for example. And perhaps most importantly, it defines goals for the patient from their perspective on what they want their pain management to accomplish. In addition, you'll notice the PROMIS instruments here: depression, anxiety, anger, physical function, social function, pain interference, sleep disturbance, and fatigue. These are all based off of a sample that represents the US population, so it's not really a convenient sample. And if you're at the 50th percentile, for example, for physical function, you're at the 50th percentile in that parameter for our general population. And then you'll notice the little arrows pointing to better health. And so it's an easy way for clinicians to assess very rapidly in a variety of different domains how their pain management plan is working in a particular patient. Perhaps one of the most significant things that's happened within the DoD is the fact that we are seriously looking at integrative health. One of our biggest critics, David Gorski, has often mentioned that integrative medicine is a sham and it's too close for comfort, but I will remind the audience that the father of Western medicine and the allopathic tradition notes that it's so much more important to know about a patient than it is to know the disease that the patient has. And I think integrative health certainly helps with that. And it's not a panacea, but it is definitely an equal partner with the other things that we're already using. And of course, policies have to follow up everything that we're discussing. So pain management and opioid safety in the military health system, these are the policies and the consent system that we're using with our patients to improve opioid safety and pain management. Use of naloxone within our system as a co-prescribing activity. There's been a lot of concern. Why are you giving me this drug of addiction? And we're explaining to patients, this is like the fire extinguisher in your kitchen. You don't buy a fire extinguisher for your kitchen planning on a fire, but you're sure glad it's there if you have a problem. It's the same thing with naloxone when you have opioids in the system. And then finally, the first integrative health regulation in the DoD working with acupuncture, which is historic in nature. And so we're not allowing anything into our system without taking time to look at the data. And that includes things that have historically already been there, but these things that we're adding also. And of course, please feel free to look at our website for more information on all of these activities. Thank you.
Thank you, Dr. Buckenmaier Tripp, for this fascinating presentation and very informative. We already have some questions coming in. You are very careful to point out that conventional therapies that involve, for example, interventions, procedures, even drug therapies and occasionally opioids still have a very important role in comprehensive pain management. But you've mentioned a number of evidence-based, more traditional, even complementary practices, some of which are ancient. What barriers have you encountered in introducing acupuncture, yoga, medical massage, and others into the panoply of treatments that we have?
That's an excellent question. I do just want to briefly mention I misspoke when I was talking about the sufentanil nanotab and called it Actique. That's the fentanyl lollipop. It's actually called the Suvia, developed by the DoD. Just in case anybody noticed that I had made that error. It's interesting. We used to call these complementary practices complementary and alternative medicine. And I think that terminology sort of explains the difficulty. When you say the word alternative, you're suggesting to the patient, well, after we've done medicine, we will now try these alternatives. And many organizations right now in the United States have gotten away from that terminology. And as you put it, sir, called it complementary. And the point is that these things aren't foreign, they're just medicine. And so it's acupuncture, massage, yoga, mindfulness. They're not options that are outside of medicine. They're complementary. And as we know from pain management and multimodal therapies, when you combine therapies that work through different mechanisms, and certainly the things that I just mentioned, like acupuncture, massage, work through different mechanisms than a pharmaceutical, but they can complement those things that we have traditionally used in our system, and they've, quote unquote, gotten through the wire, and they're part of the medical house. And so now we're trying to make these integrative health modalities part of the medical house. And I think the problem has been, it's just, even though these have been around for millennia, for most providers, they're new. And so we're going through that process right now of learning with our patients' help how these integrative health modalities can be equal partners with the things that we do that's good medicine every day.
Yeah, but I could see that a problem there for both patients and especially care providers, those that are appropriately skeptical. And, and this effort for chronic pain management in Canada is centered around McMaster University, which has a long-standing tradition for and expertise in good evidence-based practices. Many would see these, as you point out, sometimes ancient practices as pre-existing, more modern notions of evidence bases. Is there good evidence behind these ways of approaching pain?
It's overwhelming. The issue is our system, capitalistic system, is often driven by the development of pharmaceuticals. There's a lot of money there, and there's a standard way of developing pharmaceutical. What's going on right now with the vaccinations for the COVID-19 virus is a prime example of that good science. But you can't use those same properties to look at something like acupuncture or massage. You have to come up with better measuring tools, better ways of researching that are outside of that standardized and traditional way of looking at a drug. And that's why we're so excited about the Pain Assessment Screening Tool and Outcomes Registry, or PASTER. When you start asking questions about a patient's social function, about their relationships, their depression, their physical function, you begin to level the playing field with an opioid, let's say, because now you're actually able to demonstrate value in areas where opioids have traditionally held sway. I'm an anesthesiologist. If the only thing I'm going to measure is pain intensity, well, an opioid's the best way to manage that intensity. I can get your pain intensity to zero every single time, but is that actually good for the patient? And it was our service members that were the ones telling us no. And so when you start asking other questions about what's important to them, how am I interacting with my spouse, my work life, my social life, and you begin to show how these integrative health techniques improve on those parameters, then not only does the clinician see, but the patient sees that these efforts have true value, and that the research that we're developing right now is using these tools to demonstrate exactly that. And so it's a different way of thinking about care.
Yeah, and I particularly like the notion that you raised that they have maybe been given a bad rap because they're reserved for the very end, sometimes long after things that we've done conventionally have failed and maybe even injured people. So the notion of starting earlier is a great one. I want to finish. We're short of time here, but you raised such an important point about the dialogue between the team and the caregivers and the patient, and how this new Defense and Veterans Pain Rating Scale has changed that dialogue by looking at more than just the color scheme and a digital analog scale. Can you talk just a little bit about that dialogue and how it changes?
You know, I mentioned Hippocrates during my discussion, and I actually keep the Hippocratic Oath on my desk. He was the one that first reminded us, as part of the allopathic tradition, that a physician, first and foremost, is an educator, a teacher of health. And so the communication with a patient about their pain has to involve that education. And working through the scale, particularly the Defense and Veterans Pain Rating Scale, helps the patient understand that pain is not just about lowering intensity. It's about maximizing function, both physical and emotional function. And patients, as I mentioned, actually do listen to us. And if we prioritize those issues, they become priorities for the patients. And when you're prescribing both integrative health and other modalities, particularly pharmaceuticals, that lead to improved function, they see that as success. And this opens a whole world to mindfulness, meditation, yoga, massage, things that are non-pharmacologic that have a very high therapeutic index, but at the same time are extremely safe.
Thank you very much, Dr. Buckenmaier, for the fascinating presentation and for answering those questions. And it's over to you, my friend.
Thank you very much. Merci beaucoup, Eric et Trip. Et j'ai apprécié la présentation et l'importance du traitement médical, mais aussi des approches complémentaires. Et aussi l'autre point qui est important, l'implication des vétérans eux-mêmes dans leur propre traitement. Très intéressant. Alors, notre deuxième présentation sera effectuée par le docteur Brenda Lau, qui est la cofondatrice et directrice médicale d'une clinique interdisciplinaire novatrice de douleurs chroniques à Vancouver. Dr. Lau is co-founder and medical director of the CHANGEpain Clinic in Vancouver. She is also a clinical associate professor at UBC's Department of Anesthesiology. She's the founder of the pain medicine subspecialty of the Royal College of Physicians and Surgeons of Canada. Dr. Lau will explain the usefulness of remote care for veterans suffering from chronic pain that we've learned from several clinics across Canada. La Dr. Lau sera accompagnée d'une jeune vétérane de l'armée canadienne, Angel Kibble, qui témoignera de l'utilité des soins à distance. Corporal retired Angel Kibble is a partner veteran from the Canadian Army, from whom we'll hear as well today. Je vous rappelle que vous pouvez poser des questions pendant la session en vous assurant d'être inscrit avec le panneau à droite et en soumettant vos questions par le même moyen. Dr. Lau, à vous.
Merci, Michelle, for the kind introductions. My talk is going to be focused on the learnings of online services from 9 pain centers across Canada. And this work was only possible because of the Chronic Pain Centers of Excellence, but also COVID. So when COVID hit us this year, it really ushered in a new era of healthcare innovations, especially in online services. And in this way, we see a huge number of innovations that came through that I want to speak on today. But before I do that, the innovations are only so good as the people we serve. And I'd like to hear from one of our heroes today. I'm honored today to introduce to you Angel Kibble, Corporal, retired. She is a Canadian Army veteran. She is a peer support, chronic pain patient for over 10 years, and she enjoys spending quality time with her family, service dog Teddy, and being out of nature. So Angel, thank you so much for joining us today. Can you share with us your experience with individual and group online services, medical services so far?
Thank you, Dr. Lau. I'm a veteran and I live on Vancouver Island, which for me, it requires me to travel from here to Vancouver to access services at the clinic. This is exhausting, it's expensive, and it's very time consuming. Myself and others who live with pain and also PTSD face extra layers of challenges the average person don't. This includes the anxiety and travel, increased pain levels, just being around strangers, and honestly, asking for help. Access to online options for group medical visits and one-on-one, whether it be with a nutritionist, a general practitioner, or a specialist, helps really take the pressure and strain off of the medical system, providing much needed education to veterans and their families as well. Families are able to access these services online, and collectively, this helps reduce medical burnout. Online treatment cannot replace all medical appointments, of course. However, online medical visits that I have experienced have all been quite well suited and designed for the virtual setting. While face-to-face care has always been the standard, honestly, the world is changing and we need to change with it.
I hear you, Angel. That's why we've been innovating this along with you and so many other patients. The first step towards getting somewhere is to decide that you're not going to stay where you are. So we're not going to stay where we are, Angel. Before I start my talk, the disclosures of the work that I do, they cut across multiple advisory boards for policymaking, clinical work, education, such as the Royal College, and as well, I focus on my role as a co-founder and medical director of CHANGEpain Clinic. CHANGEpain Clinic is a multidisciplinary clinic that was opened in Vancouver in 2013. And as of this year, we have over 50 interdisciplinary members. We're recognized in the areas of education and also in specialized therapies like infusion therapy. And so we're really proud to be one of the recognized pain centers of excellence with the Pain Centers of Excellence with VAC. Really, our talk today is going to focus on 3 parts. The initial few slides are on the background information of our participating centers, and then we'll go through common challenges and the benefits that we've seen. We had 9 centers that we were able to get our survey out to just to see what they had experienced. It was basically cut across the board, about 3 of them in Ontario and 1 of each in various other centers in the province. They were half of them located in the community areas and another third or so at the hospital levels. And these make a big difference because of the way they can roll out the services. And again, as I mentioned, because of where they're located in the types of institutions, that also governed how many patients that they could start with online services, because it really depended on their institution's priorities at the time. So at least half of our centers could access more than 100 patients with kind of an online platform, phone platform. They were able to move their technologies that way. All of our centers faced many challenges. I'm going to cover 4 key ones. The first one was around accessibility for patients because of funding. The different centers were all differently funded. Some of them had a mix of third party to some of their Ministry of Health-based services. In BC is MSP, in Ontario would be OHIP. Others would have access to like third party funding, Great West Life, their motor vehicle branches. So depending on their funding, it really therefore governed how many patients could access. A second major challenge was the physical organizational challenges. Every center expressed this lack of support that was immediately available, whether by the province or within their hospital or clinic. Either there wasn't enough personnel or there wasn't enough equipment to start off with. There was concerns expressed about even confidentiality. So there's even in some centers hesitation to approve their clinics to go online because of issues with the technology and not being sure of how this can be protected. So again, a lot of learnings from since those early days in March. Particularly in our center, we had organizational challenges related to the groups. We had ability, particularly in BC, to do this under medical services plan. And that meant that everyone had access to this if you were a BC resident. But it meant that there were so many more administrative needs placed on us. In fact, about 40% more, whether it was our providers' clinical and technical difficulties, or it was the patients having problems signing on. There's just a lot of logistics to have to overcome. A third major challenge that all of the centers found was actually patient related. This was computer illiteracy. It was access to technology. It was even as we found, unfocused patient behavior. It was really different, if our patients were in front of us in a room. But we found that online, many distractions were in place. And in particular, because of COVID and many people now working from home, this was now a time where people did not always have a luxury to have their own private space with their healthcare providers. And again, confidentiality was sometimes expressed by our patients as well. Psychological implications was something of a barrier for some people. And this is why we found across the centers, only certain people really were better suited for online. And this may have been phone or even some of the Zoom or electronic medical platforms. But this meant that people had to have compatible equipment. This meant that they had to be willing to do online services and be willing to be in this wait period because it wasn't always starting exactly at that appointment time. They had to also not have significant mental health barriers. PTSD, we found, where blue screens, computer screens, were in fact a trigger. So therefore, certain people really could not access online therapies in a way that would help them. A fourth challenge that was found by most centers was a monitoring evaluation. As I mentioned, most of us really got thrown into the online space when COVID hit. And so you can see from the statistics in the far right side, about 5 of the clinics, half the clinics started their online services in a big way around April. Even one started before that, but half of the other half started later than that. So the data is really quite variable, but the generality in terms of how they've evaluated their effectiveness is really resting on, patient satisfaction, how the clinicians have felt about it, but also maybe more objective measures like readiness to go back to work and psychological evaluation. So this is evolving. So I'd really like to focus on benefits. And in this way, we didn't have a chance with this online survey to really pull out the individual benefits because there was a short period of time in which to present. But here are some very unique yet also cut across benefits for the centers themselves. We knew that benefit number 1 for patients was that travel time was now overcome. Half of our patients traveled well over an hour to get here. And Angel's story is very poignant. She lives on the island. It takes her an entire day if she were to come just for a medical appointment. And so now in the comfort of her own home, she can attend multiple medical appointments and even medical group programs without leaving her home. The breadth of content was also a huge breakthrough. This graph here depicts the number of sessions we offered starting in March when we went online to this day. Weekly, these numbers show that we went from 4 online up to even a peak of 76 in the middle of COVID phase 1. And we've steadied ourselves to, on average, about 36 sessions per week. And again, there can be a whole talk on the logistics. Benefit number 3 was related to the staff engagement. The bars in blue, cut across board, shows all the questions when we ask, despite the logistical issues and frustrations faced from patients, staff hugely favor delivering online care because of how much help they see. These next couple of slides really emphasize the numbers reached, and a huge number are changed when you don't have geographic barriers. In 2019, we saw about 3,400 patients in the span of May to September, and these were various physical appointments. You'll see in 2020, the same span of May to to September in 2020 saw well over 24,000 patients. And that meant that 11,441 patients of this number were in fact group medical patients. So it was a huge increase in our ability to reach patients. You'll see in this graph. And the 5th benefit, which is in fact quite unique to BC because they transformed all of their medical services online. That meant that the 19% of those without GP could now access medical services if they were able to access a GP-led group medical service. And so we are one of those clinics that was able to offer that kind of access. That meant that with our specialist clinic, a patient could now immediately access any of our services without even the delay in the wait times to see a GP. And you can see that delays in the pensionable benefits that are often experienced by our veterans, and for good reasons. It will average 6 months to even 2 years, and the data from the VAC showed about 236 days. And so we know that now something like this innovation to access medical services, it would be a very important innovation to try to keep. So the key learnings are the following. We know that there are some major barriers related to equipment, technical support, support admin in the clinics. We know the interventions are not for every person or even every practice. There's still a lot of evolution in the way we're trying to find out the best timing, the content, and the breadth and reach. We know we have to evaluate these in order to find out what's the most effective for our patients and our veterans and their families. But we've already seen the immense benefits just from the sheer number of people that we can reach. So thank you for your time. And I thank you, veterans, for your service. We hope that this kind of work is the kind of innovation that's going to help you better, faster, and earlier.
Merci beaucoup, Dr. Lau, pour cette présentation. And Brenda, I know that you want to wish to thank a few people here.
Merci. I do want to show my deep gratitude to the Chronic Pain Center of Excellence for all their support. Without that, this research could not happen. So I want to recognize the CHANGEpain Clinic team, and especially our medical and research director, Dr. Emmanuel, and all of the 9 centers for all their hard work just to make the services happen so we can get this data. So thank you very much.
Thanks, Brenda. Now we're going to go into the question period. And the first question, these are questions that you submitted before or during the presentation. The first question is for Dr. Lau. Do you think the use of online care will have an impact on access waiting times?
So already the data shows, and this is a very short window that we were examining from May to September of this year, or March to September this year. But the numbers are huge. We already know access is overcome when geographic barriers are overcome. But one thing that we never really talk about a lot is also family access, because here we forget about the huge logistics and the impact it has on families to support their veterans or patients going to medical appointments. So access in terms of sharing the education pieces, sharing the medical appointments, but also in reducing the amount of impact it has on families in getting that medical access and healthcare appointments is significant. So yes, in short, online care has a significant positive impact on increasing access.
That's excellent. Thank you very much. Now for a question for Angel. Angel, what is the one thing that you may have learned from your pain management program and the care and services you've received that has made the biggest impact on your life?
Thank you, Michelle. Honestly, there hasn't been one thing. The one thing was creating that team, creating the team to support me, and the one that was going to work with me rather than being dictated what's going to work for me, because honestly, I know my body best. And working with Dr. Lau, she knows I know my body. So having a team that works within and with me, not for me, or if that makes any sense, and having that multidisciplinary act to it, having the blend and in one house of someone having access to nutrition and supplements and yoga, sleep, meditation, all kinds of different classes. Just that whole multidisciplinary approach is so crucial, and having it in pretty much under one umbrella really, really helps.
Thank you. And in fact, I'm going to kind of turn it back over to Dr. Lau. Perhaps you could comment on this whole interdisciplinary approach to chronic pain care. I think it's a crux of some of the things that we've learned.
Yeah, absolutely. I mean, Dr. Buckenmaier really, in a very short span, gave an excellent overview of really the updated science and our approach to pain. And we often think of pain as the physical level, some bone, soft tissue, some muscle, something hurting. But really, pain has to be embedded in much more than just the physical tissue. There is the nerve system, there's the gut system, and there's the way the immune system interacts. So what Angel was talking about, what Dr. Buckenmaier was talking about, is this broad approach where we're looking at not just the causes of pain, but also what perpetuates pain, but also that when people are working, going to school, they're in their families, how pain interacts and impacts all of those activities. And that's why Dr. Buckenmaier's emphasis on function is so huge. Interdisciplinary support isn't just one pill. It's not one procedure. It's not even just one physical therapy. A whole person requires a whole person approach, and pain needs all of those supports. Not every person needs a 20-member team, but we do need a multimodal way of looking at the pain. So that's just not a score on a 0 to 10. That really encompasses what interdisciplinary means.
Yeah, it's very interesting. And the important thing as well is to find out or diagnosing really where does the pain come from. And sometimes you can misplace, you can misdiagnose, and it's extremely complex. I understand that. Now, again, for you, Dr. Lau, what are perhaps some of the strategies for identifying just what we were talking about, the causes of chronic pain, and how would online services, online work complicate these strategies or help them?
It's both, actually. So we know that at the very core, pain does happen to the body, and you have to have functioning nerve and nerve inputs for you to sense pain. So all of it has to happen to understand, is it bony, is it muscle, is it ligament, but is it immune system, gut system? So you need diagnostic tests. And a number of us are, used to various scans, MRIs, CTs, maybe there's lab tests that are appropriate, but even the actual physical therapies, our examination is all part of that diagnostic process. So online therapies or online access doesn't replace what you need to do face-to-face for those kinds of diagnostic tests. And just like Dr. Buckenmaier had talked about all various different types of therapies, even the response to a therapy or a non-response to a therapy gives us that data to understand what that causes. So in general, the actual doing of the tests, undergoing of the physical therapies requires that one-on-one. But the online part is very complementary because the huge education piece, even education around what that test is coming up, is going to impact you or how it affects, the timing of your day. All those things make a difference in reducing anxiety, reducing the stress around doing the diagnostic process. The online therapies are particularly beneficial, as you can see with Angel's story, with consultation, with follow-ups after these tests, with understanding your game plan with your team. A lot of this doesn't have to be face-to-face and can save people huge amounts of travel time. So really we see online as a really a necessary complement to our current face-to-face care.
Yeah, very interesting. And it's interesting that it's some of it is a fallout of the whole COVID issue, isn't it?
Yeah.
Now a question for Angel. Angel, if you had a chance to speak to other veterans, what advice would you give them in terms of those who are suffering from chronic pain?
What advice? I would say, number one, it's okay to not be okay, and it's okay to ask for help, and really finding that team. You have to build your tribe. Once you build that tribe, you build a relationship, you build trust, and you're able to start accessing trust again in people, because I know a lot of us, we lose our trust. But you have to advocate for yourself to get there, because it's not going to happen overnight, and it's not going to fall on your plate but with some advocacy and also stuff like this, the Center of Excellence, it's making it easier to access these things rather than trying to build your tribe on your own. And truly, you have to show up for yourself because you're the one who needs it. And you can show up and be just a shell in the room or, you know, being a part of whatever program. But if you don't show up for yourself each and every day, if you don't do the actual work, nothing's going to help. So do the work because it's all for you.
Angel, that's great advice, and I'm sure that those veterans listening in will heed that advice. And I guess I can throw it back to Dr. Lau to talk to us a little bit or comment a little bit on actually the veterans themselves participating in their own care and being involved in kind of a shared approach.
We always know that it has to be 50-50. It has to go both ways. Gone are the days where the health provider, in particular the doctors, tell you what to do. That we know that top-down approach doesn't work, but we also know embedded in the military culture is somewhat of that top-down approach. And so we understand that part of that transition requires now this shared dialogue. You have needs that when you express it, allow us to know what your priorities are and how we can start to help you with the transition, but also with the care that makes sense for you and your families. Just because something responds to a medication or procedure doesn't mean that's actually going to solve what is really hurting you. It could be hurting you mentally. Something could be hurting you within the family. Something can be hurting you within the way you function and move a body part. And a single medical therapy is not enough. And that's why when Dr. Buckenmaier had mentioned this need for a kind of a multimodal approach to, at the same time, address several function and several priorities. We need our veterans and their families actually to share with us what they need from us first, where they're ready to move on their plans. And second, what plans make sense? Because just because a recommendation is made, sometimes the timing's not right. Sometimes psychologically you're not ready. Maybe your body needs actually a graded approach before you can do something that's a little bit more fuller. And also it's the readiness of the whole family because we cannot leave them behind. Without all of that in terms of support, and some of us, in fact, don't have family, but you have circles of friends and others around you. So we always have to embed your care with the circles, your communities around you. And if you don't have a community, that's even more important why this dialogue needs to be very open. That needs to also address the social, psychological, and the well-being aspects that go beyond a single medication, single procedure. So really in summary, Michelle, this dialogue needs to be open. It needs to be gradual. Angel said that last, but most important was trust. And we all take time in our own ways to establish that. And only then, truly healing, the connection between human being to human being, not just a doctor to a patient, really occurs. So that's why that dialogue is needed.
Thank you. And we only have about 30 seconds to go. But one question came in through during your presentation, and that is specifically what services can be provided online, and what services must be tailored to work around the online environment. In a few words.
Online can be through consultations, follow-ups, any education, any narratives that may be helping to explain, let's say, your plan. But what needs to be not online are physical therapies, procedures, diagnostic tests like MRI imaging, blood tests that really need for you to have one-on-one care. Those are the breadth of the things that we can do online.
Okay, thank you very much. Merci beaucoup, Dr. Lau, Angel. As you've shown, online services can help veterans with chronic pain and can actually expand the access to care and the delivery of pain management services, although we understand that there are still some challenges to overcome. I'm now going to turn it back over to Dr. Schoolmaker for closing comments. Eric?
Thank you, General Maisonneuve, Michelle, and thank you, Dr. Lau and retired Corporal Angel Kibble. I want to begin by expressing gratitude to all of the patients who have joined us for this series, how important your voice is. If you've been a part of this program for the last 2 weeks, you've seen the close sharing of common problems between the Canadian and US groups who are tackling chronic pain management. You've seen and heard from Corporal Kibble today, from Angel, as well as from the US team, the importance of changing the dialogue with a patient. You've also heard about the importance of employing and then safely delivering a multidisciplinary team approach with access that is enabled by information technologies to overcome the challenges of this remote care that enables the patient to begin with his or her own self-care and then engage primary care and the specialty groups. We're going to be addressing that in the later speakers in the weeks to come. I want to urge anyone who is watching today to register for our sessions that will pick up again next week, and to spread the word to your colleagues and your friends. Thank you very much, and back to my colleague, Michel Masseneuve.
Merci Eric. Alors, ceci conclut notre deuxième dans la série de 4 webinaires. Merci à tous pour votre présence et vos questions. Thank you to the entire COE team for putting on these series of webinars. As you can see, the Chronic Center of Excellence for Pain emphasizes interdisciplinary services for chronic pain management. Our approach is also one of a shared dialogue between veterans and those who are providing them pain services. We want to listen to the veterans themselves and ensure they have a voice in their own care. In this way, we want to provide our veterans with what is perhaps the most important thing, hope. Je vous invite à consulter notre site web et à nous adresser tout autre commentaire. Je vous rappelle que notre prochain webinaire est dans exactement 1 semaine et traitera du modèle de traitement de la douleur par étapes. Thank you for your presence at this first webinar and your thoughtful questions. I also, much like Dr. Schoolmaker, want to highlight the excellent collaboration with our US colleagues. It's a privilege of us and an honor for both of us to be working to collaborate to help veterans from both countries to get care for their chronic pain. Remember that our 3rd webinar will be in 1 week from now. We'll deal with step care for pain management. In the meantime, I invite you to go to the Center of Excellence website and send us any comment you might have. À la prochaine.